Correct.
So
So
what?
we'll just, I prefer to inject directly without putting any air bubble inside the eye. Uh,
So
Look in the light, sir.
what lens are
Uh,
you going to be implanting, Shail?
So, viscode, yellow one. So, ma'am, we are planning a trifocal toric for this patient. So I think with the advent of newer generation trifocals, I think the problems that we all face green provis with the issues of halos, glare, quality of vision, waxy vision have reduced significantly, and I find particularly this lens very useful for even for active, even operating surgeons, they find it very useful. Second side port, left hand में side port, right hand में Hoskin. Yeah. And this patient, he's been on he's on dialysis 3 times a week for the past 1 year. So I think these are the cases where these lenses really make a difference in improving the quality of life significantly. The spatula in my left hand. Yes, sir. So I like to stabilize the globe while making the main incision, placing the keratome at the limbus, and with my left hand I am pulling my globe towards me, and my right hand is going and pushing as if it wants to go and hit the endothelium. Of course it will never happen, but that's the aim. I prefer to do the capsulorhexis with a cystitome. Left hand से ये ले लेंगे. And it's a good idea to remove light में देखेंगे sir, to remove these bubbles before we start so that it doesn't hamper. In a soft cataract, this is a soft cataract, sometimes it's little useful to make a slightly larger rhexis than what you would normally be doing, because quite often you end up in a not a very pleasant situation of the nucleus not completely dividing this way, that way, and you need a little more space for the nucleus to come out of the capsulorhexis. So this is specifically the area for which I wanted to stain this capsule, because it's very often with the flap getting bunched up and the glow getting lost that you end up in trouble in these areas. Hydrodissection. For hydrodissection, I prefer to use a modified cannula modified by Dr. Akahoshi. If you see, it's a curved cannula. So unlike in other cannulas where you tent up the capsule, here I am just placing it on the surface of the lens and injecting, and we can see that wave passing through. And because there are cortical capsular adhesions here, light में देखेंगे sir. Right. I am going to do a little multi-quadrant hydrodissection even in this area of corticocapsular adhesions that may help to free it up faster. It's okay, sir. Phaco probe and chopper, yes. लाइट में देखेंगे सर, राइट, स्टेडी रखेंगे हो सके उतना. Custom one. So in a soft cataract, I actually do not attempt to chop, because quite often in the soft cataracts, they are generally not choppable, and then you end up in a bowl more often than not. So this is typically described by Dr. Ron Yeo, these cataracts, as neither here nor there kind of cataracts, where you think you can chop and then you end up in trouble. So the easiest or the safest technique for such in-between cataracts I find is the 4-quadrant technique. And I'm keeping a very low flow rate of only 14 cc per minute. Light में देखेंगे sir, थोड़ा नीचे. Can we have some saline or methyl on the cornea? So that sometimes if it's very soft and even if you go through, because your flow rate is very low, the chances of catching the capsule are not very high.
So you're classically doing a divide and conquer type of a technique, Shail, or
Sorry, ma'am?
is it somewhat like a divide and conquer technique?
Yes,
that
ma'am.
you-
Ma'am, yes, absolutely, ma'am. Absolutely divide and conquer. Yeah, yeah. Absolutely. So you try and attempt to make a cross, uh, and once you feel the plates are thin enough in the center, you go ahead and divide them manually or mechanically, as may be. So this is what typically happens. You get a lot of this soft kind of cheese wires and muck that comes. Quadrant removal, please. So I'll have an nozzle of 30 and a vacuum of 350 with a flow rate of 20 cc per minute, which I find quite comfortable and safe for all grades of cataracts. And I bring the fragment to the center, and whatever manipulations I'm doing with my left hand. So I'm trying to keep my right hand absolutely stable in the center so that the fluidics are directed in the center of the eye, and therefore iris misbehavior is quite less. So I bring it to the center, then with my left hand detach it, push the fragment away, and then I go on the side and on top of the fragment. This helps in, maintaining the carouseling effect of the torsional more appropriately. And if you can avoid complete occlusion, any machine, whether it may be Centurion, Active Sentry or anything, if you avoid total occlusion, the chances of surge become very minimal. So aim is to avoid total occlusion, and therefore I am not coring into the fragments, as to say. Light में देखेंगे sir, थोड़ा नीचे, very nice. And generally I prefer an IOP between 20 to 30 in most situations. There are eyes which are extremely high myop, where for all situations I'll use an IOP of 20, but typically when we kind of remove the fragments, I prefer to increase the IOP a little bit.
So I think that was an excellent demonstration of divide and conquer.
Left hand.
And of course, management of soft cataracts.
Yes, left hand is good. Saline on the cornea.
So whenever you come out, you always put viscoelastic.
Yes, so this is what Dr. Bobby Osher has always taught us, irrespective of the type of cataracts, to consider closed chamber technique.
So because this is a soft cataract, the cortical bulk and the cortical material is also there, which needs to be aspirated. You would be using a bimanual?
Yes, ma'am. I prefer using a bimanual. And I keep the IOP at 30. And the vacuum I increase to 400. So all these white areas that we see, those are the corticocapsular adhesions, which generally resist. So therefore, swiping movement, something that Dr. Viraj taught me very early on, which is the POPS technique, which is position, occlude, posteriorly detach, swipe, and only then bring it to the center.
So I think, I mean, of course, it's a personal preference, but I feel bimanual is a little slower than coaxial. That's because I think the port is bigger, so you can catch more matter of the cortex as compared to the
Right hand mein viscode.
as compared to the bimanual.
So your preferred choice of eye aspiration is by coaxial, Dr. Namrata?
I always do coaxial.
Always do that. I tend to use coaxial much more than bimanual. Only when I'm stuck with the subincisional cortex, I tend to use. Otherwise, I agree with Dr. Namrata. Coaxial makes the things bit faster as you aspirate much more material of the cortex because of more diameter of the port.
Absolutely, sir. And I think a lot of these things depend on how you have kind of learned during your training period.
Exactly, exactly.
Uh,
What it's a personal
when you are
preference,
kind
yeah.
of, used to one method.
But you have very nicely demonstrated how you are circumferentially moving the cortex, loosening it, and then pulling it in the center, and then going full ahead with the aspiration, so that in the central safe zone, you aspirate where the chamber is deepest, and there are hardly any chances of catching the posterior capsule.
Sometimes you have to crush some of these corticocapsular adhesions because they are so tough and so tenacious.
No, at times I think because the cortex gets mixed with the epicortex also, so
Probe
it's
it in my left
too
hand.
thick, for the phaco probe. It's
Left hand.
too dangerous for the phaco probe, and too it becomes
Exactly.
easy
It
with
becomes
the.
a bit risky holding this soft, sticky cortex and epinuclear plate.
Okay,
Yeah,
so
I'll load that. So now this is cohesive viscoelastic, which is pro-vis. So during the surgery, if you saw, the first injection that we made was viscoat, which was followed by pro-vis. So this classical soft shell technique that Dr. Ashinoff has taught us, Lester Hook. And in between, when I was withdrawing the instruments, what I was injecting was a dispersive viscoelastic, which is viscoat, so that there are, this cohesive comes out easily. So to avoid that, we do that, if you don't mind, can I load the, okay, the lens has already been loaded. So this is a Clarion panoptic toric. I've just made a mark here manually because it's not visible on the screen, so just for the benefit of the audience. Can we put some BSS on the cornea, please?
So what do you think are the benefits of the Clarion platform which has come as opposed to the earlier platform?
Light mein dekhenge, sir. So ma'am, the main, I think it's a kind of, I would say it's a kind of evolution on the existing solid platform that there was. So most of us who have been using the Acrisoft platform never had any major issues for anything, particularly as far as the toric version goes of any lens, because the stability is superb. I think the advantage Clarion has given is two things. One is the little negative that was existing with the Acrisoft platform, glistenings, although which didn't bother the patients very much, but that was one negative factor which has now been taken care of. And because the little bit of water content has been increased in the IOL, it's become a little easier to manipulate, and it doesn't remain so stiff. I think that will be more useful, particularly in the north of India in winters, where sometimes the IOLs become so stiff in the ORs that they open. So I think these are the two major advantages or changes I believe have occurred with the addition of the Clarion material. Saline on the cornea, please. And if you notice, I went behind the IOL to make sure that the irrigation drives the cohesive viscoelastic out, and the cohesive viscoelastic comes out as one bolus. So, it's easier to aspirate. What you see moving around these fibrils, these are the dispersive viscoelastic. So that's a good sign that the dispersive viscoelastic stays right until the end of surgery and it doesn't get washed out. Can we go to the polish mode? Now it's typically impossible to, align both sides perfectly because of the parallax. But if your three dots are parallel to the two marks on two sides, that means you're within 3 to 4 degrees of the intended placement axis, which I believe I'm little off at the moment. I'm just rotating it, looking at the screen here. Saline on the cornea, please. Saline on the cornea, thank you. So I think we are pretty much at the alignment area now. And even in the end, I want to make sure that I don't, destabilize the chamber and don't allow the IOL to move forward, and that will allow also it to rotate. So I'll hydrate the wound, Mary, hydration.
So I think that was a wonderful demonstration, Shail, step by step. Demonstration of all the steps which have been done so well, and divide and conquer personally I would say I saw after a long time. So excellent, and there are a lot of young ophthalmologists sitting here, and I think they were great teaching tips.
I think that divide and conquer is the fallback for any case. Even in the
Yes.
densest of cataract, if you cannot divide the plate, go ahead, sculpt, and you will be able to do it. So
Yes.
this is, I think, the fallback technique for any case,
Yeah,
and I think it's a must for all surgeons.
Yes, yes. We all
Very
have
true.
started from divide and conquer only. So thank you so much, Shail. I think
Likewise.
with this we move on to the
Thank you so